Hello, everyone, and thank you so much for inviting us here to speak about medical decision-making. So we're both, as you've heard, both physicians and teachers at Harvard Medical School, and in these roles, we've spent a lot of time working to stay up to date on the latest medical information and advances. And one thing that we have found striking is that despite all the recent advances, the application of scientific principles to modern medicine, and all the sophisticated data analysis that is available to us, there still seems to be an incredible amount of controversy about, among experts about how to prevent or treat even the most common conditions. And this kind of uncertainty is very unnerving, both to patients and to physicians. So why are the experts disagreeing? Why isn't there a clear right answer? And how do physicians make their recommendations and patients make their decisions in the face of this kind of controversy? This is the question we set out to answer. So we're going to start just by showing you some slides about medical controversies that have been featured in the lay press. Other way? There we go. So should everyone with elevated cholesterol be treated with a statin? Several years ago, new guidelines came out to address this question, and almost immediately there was intense debate, with many experts arguing that too many people would be treated without benefit. What blood pressure needs to be treated? The guidelines keep changing, and experts disagree. Just in the last few years, the blood pressure targets were tightened with the SPRINT trial, then loosened, and now tightened again with the final analysis of the SPRINT trial that was published in 2021 in the New England Journal. Other studies have even raised doubts about one of the most basic and accepted approaches to the treatment of hypertension, the low-salt diet. A recent controversy centers on aspirin for primary prevention. Should healthy adults take aspirin to prevent heart disease and stroke? The ASPRI trial raised questions about this widespread practice, especially for older adults. And I'm going to show you three headlines that came out on the same day based on the same data. The New York Times, based on this study, said that
you have to press it.
that aspirin may not be needed. And NPR said, well, there's no benefit. And NBC, the experts quoted by NBC, said it's actually harmful. Another controversy has been in the news centers on vitamin D. Should everyone take vitamin D? And if so, how much? What is the normal level of vitamin D? And should we even be measuring vitamin D levels? So these two headlines came out on the same day based on a report from the Institute of Medicine. And the experts quoted by the New York Times said extra vitamin D is not necessary, and the experts looking at the very same data and report from the Wall Street Journal recommended that you triple your dose of vitamin D. And this debate intensified very recently after the VITAL trial that was published in 2022 that showed no clear benefit of vitamin D for many people, even for fracture prevention. You can see the report below there from The Lancet, which emphasized that despite enormous number of studies on vitamin D going back as long as 100 years, there's still a tremendous amount of controversy and lack of agreement on what to do. I'm sure you're all aware of the conflicting recommendations about cancer screening, at what age, and how often should a woman have a mammogram. Do mammograms even save lives? This has been extensively debated over the last decade, And in this slide, you can see that the expert panel reversed their prior recommendation, now recommending breast cancer screening beginning much younger than they did just a few years ago. The debate about prostate cancer and PSA screening has been everywhere. Should a healthy man have PSA screening? So this debate was supposedly settled in 2012 when the government panel listed there, the USPSTF. They said based on the available data, nobody should have routine PSA testing. And then just a few years later, they reversed their position. So we want to emphasize that every one of these controversies and lots of other controversies, for example, what are the indications for spine surgery, are active and in the public eye. So your patients are seeing this information in the lay press. So how do physicians and patients make their decisions in the face of this kind of controversy? We didn't have a ready answer, so we began to search.
We went back to the textbooks and looked at classic medical decision analysis, which is derived from economics. A formula is used to calculate what is the best decision. The formula was derived by Daniel Bernoulli, who was a mathematician in Holland in the 1700s. Now, Bernoulli was looking at decision-making in the marketplace. He said the best choice is calculated by looking at the probability of a certain outcome and multiplying it by the utility or the impact the outcome has. Now, in economics, the probability of an outcome might mean the chance of selling a certain number of products. The utility is basically the profit in dollars, the impact on the bottom line. The formula that you see underlies much of economic decision analysis. But when applied to medicine, yes, you can estimate the probability of an outcome. For example, consider treatment of prostate cancer. You can look at the probability of an outcome of a side effect like urinary incontinence. But then the question becomes, how do you put a number on the second part of the equation, on utility, the impact it has on your life? So there are three different methods that have been used in classic medical decision analysis. The first is a linear rating scale from 0 to 1, where 0 is death and 1 is, quote, perfect health. You're supposed to look at the scale and say, well, if I had urinary incontinence, my life would be at this point between 0 and 1. Another method is called the time trade-off. How many years of life would you be willing to trade off or give up in order to avoid incontinence? And the third, if you can believe it, comes from game theory. And that is you're asked to imagine there's a magic pill that can prevent a certain outcome, such as incontinence. And then there's what's called the standard gamble. You're asked to imagine that this magic pill that can prevent a certain outcome, such as incontinence, in a certain percentage of cases, it causes instant death. So we have a casino close by, and you're supposed to estimate the odds that you would be willing to take to completely avoid a certain outcome versus the chance it might kill you immediately. Now, recent research in cognitive psychology has shown that these three methods are all severely flawed. The problem is you cannot reliably forecast your life in the future. You can't accurately understand the impact that a certain outcome will have if you've never experienced it. Also, as this audience well knows, medical conditions are not static, they're dynamic. And people adapt. So the impact on your life is changing over time. Despite this, these three methods are broadly used in terms of deciding what is best. They're used to calculate so-called QALYs, quality adjusted life years, set priorities in the United Kingdom, where they ask healthy British citizens, how much time would you trade off for a medical condition? And in the United States, they're proposed as the basis for cost effectiveness as part of healthcare reform. Now, what happens when you ask people who actually have the medical problem or the condition? For example, healthy people in Britain, healthy people, say that being blind on a scale of 0 to 1 is 0.5. That is, the utility of your life is diminished by 50% if you can't see. I happen to have a first cousin who's blind. She worked as a teacher. She speaks several languages. She's currently retired and volunteers in an assisted living facility. If you told my first cousin that her life was 0.5 on a scale of 0 to 1, she would slug you. So when you speak to people who actually have a certain medical condition, their assessment of their own life is very, very different than what people who are healthy or never have experienced the medical condition believe. So this entire structure of medical decision-making is deeply flawed. In fact, Daniel Kahneman, the Nobel Prize winner in economics, who pioneered cognitive psychology, gave an address to a medical decision-making meeting where he said, this classic paradigm of measuring utility is like measuring the ether in 19th century physics when the ether did not exist.
So we realized that the textbooks were not giving us the answers that we were looking for. And then we thought about Sir William Osler, one of the most famous physicians of all times, practiced in the late 1800s and early 1900s, and he made the following comment about making a difficult medical diagnosis. He said, listen to the patient, because if you know how to listen, he's telling you the answer. So we decided to do field research and listen to patients. So we interviewed scores of patients in great depth and asked them how they made their medical decisions. Patients of different ages, from different parts of the country, from different socioeconomic backgrounds, and, of course, different kinds of medical problems. And although we found that people were individual in how they made their decisions, we also found common threads in the approaches that they took to their health and medical problems. And to explain these common threads, we'd like to include all of you in a thought experiment right now. And we want to begin by asking you to think about your own experience when you have been the patient. So think about your experience as being a patient in the past year, maybe a checkup, a visit to your doctor for a problem, or maybe even something more significant, a visit to the ER or a hospitalization. Now try to remember the experience of being a patient, put yourself in the mindset of being a patient, and now imagine that you were sitting in your doctor's office and your doctor tells you that your blood pressure is too high. And even though you've been exercising, you changed your diet, you lost weight, your blood pressure is persistently elevated. And now your doctor tells you that it's time you need medicine for this problem of high blood pressure. So raise your hand if you'd like to be proactive. You want to aim for perfect blood pressure control, and you'll do whatever it takes to achieve it. Okay? Now raise your hand if you feel that your blood pressure doesn't need to be absolutely perfect. You just want the minimum amount of medication. Oops. Okay? So the first group, we applied the term maximalist. You want to be ahead of the curve, do everything and more. The second group, those are the minimalists. Less is more.
So your doctor prescribes the blood pressure medication. It turns out the medication comes in two forms. One is extracted from a natural source. The other is synthesized in a laboratory using the latest technology. But both pills are chemically identical and cost the same. Your doctor offers you a choice. Raise your hand if you prefer a medication extracted from a natural source. Okay? And raise your hand if you want the medication synthesized using the latest technology. Ah, okay. So the first group has what we call a naturalism orientation. These are people who prefer or look to natural solutions. For this audience, that would include massage, acupuncture, meditation, and sometimes herbals. The second group has what's called a technology orientation. They look often for the latest high-tech breakthroughs, cutting-edge treatments.
So finally, your doctor gives you a prescription for the medication that you chose, and you fill the prescription, and now you're sitting down ready to take your first dose. So raise your hand if you swallow it down, confident that you are on the right path to solving your problem of high blood pressure. Okay, now raise your hand if you take the pill out of the bottle, stare at it for a while, then take the package insert and read all the side effects a couple of times and wonder if you should really take it. So the first group we term believers. Believers are certain that there is a good solution for their problem. Once they find it, they're ready to go ahead. Doubters, that's the second group, worry that the treatment might be worse than the disease. So the terms of these mindsets are new. They came out of the many interviews that we did with patients, and these were the common threads that we found that reflected their approach to their health in general and to medical problems when they occurred. And these mindsets applied not only to issues like high blood pressure or high cholesterol, but also to decisions around surgery and treatment of cancer. So a group of researchers from University of Michigan heard us speak about this and read our book, and they actually developed a scale to assess these mindsets. They have conducted and published several studies. This is the initial study that I'm showing you here that validated the usefulness of these categories in predicting patient choices in healthcare, including preferences around cancer screening and treatment. Elective spine surgery happened to be something that they looked at, diagnostic testing, and vaccinations. And this was in a U.S. population, but a subsequent study by a Chinese group looked at the same thing using this scale and found that actually it was useful in predicting medical choices in the general Chinese population. So it's not just patients who have these mindsets. Obviously, doctors have them too. So now we want to get a little personal and talk about our own medical mindsets. So Jerry, you go first.
So I was raised in a family with a strong Eastern European Jewish tradition where doctors were on a pedestal. Physicians like Jonas Salk and Albert Sabin were heroes for their work with polio. Science and technology were greatly honored as well, and anything that was thought to be, quote, natural was a throwback to ignorant village life in Europe. So I was raised as a believer and with a technology orientation. And to me, being a believer meant doing everything to the maximum. The attitude was every medication, every pill must mean better health. My father in his early 50s had a massive heart attack and died. He may have died because he did not get intensive cutting-edge treatments. Possibly could have survived if he had. Of course, he may have died even with ICU care. But this experience reinforced my belief in intensive interventions. And this maximalist mindset extended not only to heart disease, but basically to all of medicine. And my choice in the 1970s to become a hematologist and oncologist fit with a maximalist point of view when bone marrow transplant was curing people with leukemia who previously were incurable. So my medical mind is that of a maximalist and a believer.
And I had a different kind of upbringing. I was the first child in my family, and when I was a baby, the doctor explained to my parents that the new scientific way to feed a baby was every 4 hours by the clock. And my dad, who was an engineer, was very enthusiastic about applying scientific principles to child rearing, so he made a very detailed chart for my mother so that she could check off the boxes and make sure to keep exactly to the schedule, and then he went to work. And my mother, staying home with a screaming baby, quickly abandoned the protocol and decided to feed me when she thought I was hungry. When my dad got home, he was appalled. He asked her, "How can you not follow the advice of the doctors, the experts?" And her response was that of a doubter. Experts don't know everything. My parents were ahead of their time with respect to a healthy lifestyle. They never smoked. They were avid exercisers. My dad used to wake my sisters and I up early to do the Royal Canadian Air Force exercises every morning. And my mother had us eating whole wheat bread, which in the 1950s was not a particularly tasty item. My parents had the good fortune, by virtue of their genes and/or their lifestyle, to live long and healthy lives well into their 90s. My dad died last year of age 99. And this contributed to my minimalist doubter mindset. So Jerry's a maximalist and a believer, while I'm a minimalist and a doubter. And we maintain these mindsets despite going to very similar medical schools. He went to Columbia, I went to Harvard, and we trained at the very same hospital, Mass General Hospital, for our residency training. So why are we telling you this? We're pointing it out to emphasize that doctors and experts have these medical mindsets too, and this can impact the advice that we give to our patients. But of course, when making decisions about treatment, we have to consider the evidence, numbers, data from clinical trials. Shouldn't these numbers give you the information you need to figure out what is best?
So one of the first patients we spoke with is a woman we call Susan Powell. All the patients we talk about today are real, but we changed their names for confidentiality. Susan is in her 40s, works as a nursing assistant, and her routine checkup with her primary care doctor was found to have an elevated cholesterol of 240, and this was confirmed, and the cutoff that's normal is 200. So Susan's an active person. She walks regularly, follows a healthy diet, does not smoke, doesn't have hypertension or diabetes. Her doctor said, "Susan, you need treatment for your elevated cholesterol. You need a statin medication." Now, this medication will decrease your risk of a heart attack by 30%. That made an impression on Susan. She said she'd think about it, but did not immediately fill the prescription. While surfing the internet, she came upon a government website that has what's called a risk calculator. A risk calculator answers a key question that every patient should ask himself or herself regardless of their condition. What is my risk of a certain outcome without any treatment? Now, in Susan's case, a woman in her 40s with a cholesterol level of 240 and no other risk factors, the chance that she would have a heart attack in the next 10 years is 1 in 100. Even if she were in her 50s and her cholesterol rose to 280, her risk of a heart attack in 10 years would be 2%, 2 in 100. So her current status is 1%, and if it got worse, it would be 2%. So you see how your mind plays a trick on you. When you hear that a statin medication will reduce your risk of a heart attack by 30%, it sounds to you as though you are at 100% risk for a heart attack. But in Susan's case, it's really 30% of 1%. or if she were in her 50s with a cholesterol of 280, it would be 30% of 2%, which is clearly different in impact in terms of thinking than what she originally heard. Now, we spoke with some patients, like a woman we call Michelle Bird, who's a maximalist and a believer, and Michelle said she would immediately take a statin medication because she said, I could be that 1 in 100 who's going to have the heart attack over the next 10 years. I'm taking the drug. But Susan was a minimalist and a doubter and was not convinced by the numbers.
But there's more to Susan's story than just numbers. Shortly after she was given the statin prescription, she went to a dinner at her church, and there she met an acquaintance who was hobbling around looking very ill and in obvious discomfort. And Susan spoke to her, and it turned out that this woman had been taking the very same statin medication that had been prescribed to Susan. And the woman had developed a side effect, the most common side effect caused by this type of medication, myopathy or muscle pain. As you know, stories like this have powerful effects on all of us. Cognitive psychologists call the effect of these stories, quote, availability bias, because the dramatic story stays in your mind and is readily available. And these stories lead you to overestimate the likelihood or probability of the same thing happening to you. So although stories can sometimes be helpful, they can also be misleading, making something rare appear likely. So when you hear a story like this, you need to know the numbers. How common is this side effect of myopathy when taking a statin? Well, it turns out that the number ranges from about 1% to as high as 10%. 10%, that might sound like a pretty large number, but if we present or frame the information in the opposite way, between 90 and 99% of people do not have this side effect. And this sounds much better, even though the information is the same. So when you're helping a patient make a decision, or when you are the patient yourself, it's important to flip the frame by presenting or considering the information both in the positive and the negative. Now, you might think that framing is primarily a problem for patients, but a Swiss study showed that doctors are just as susceptible to framing as patients are. So how do patients and physicians get numbers and other information about medical treatments? Well, in the United States, one way is through advertisements. And studies from UCLA show that Americans who watch the evening news and several hours of primetime television see more than 1,000 drug advertisements, which works out to about 16 hours, a lot more time than they spend with their doctors. And these ads are effective. For every $1,000 spent, it's estimated that 24 new prescriptions are written. So drug advertisements are carefully constructed to use the power of numbers to sell the product. So let's look how this is done. Numbers are framed in the positive. For a statin, for example, the ad will say that there's a 30% decrease in the risk of heart attack, but it doesn't say that it's 30% of 1% or 2%. It turns out that when patients hear numbers the way they are presented in drug advertisements, a study from Dartmouth showed that they typically think the medication is 10 times more effective than it really is. But this is not just a problem with advertisements. It's also an issue when you look at the results of clinical trials. So you may have seen this study. This was a report in 2013 published in the New England Journal about the Mediterranean diet. And this is the abstract from that paper. So the authors described that patients who followed the Mediterranean diet had an adjusted hazard ratio of 0.7, meaning a relative risk reduction for MI and stroke of about 30% by following the Mediterranean diet, an impressive number that was in every news report. But what are the actual numbers? So these are the actual numbers here. In the control group, 4.4% of the patients had a cardiovascular event. In the diet plus extra virgin olive oil group, 3.8% had a cardiovascular event, and in the diet plus nuts, 3.4%. So the absolute decrease in events was 0.6% in the olive oil group and 1% in the diet plus nuts group. And I think you'll all agree that if we reconfigure this abstract to say that the absolute decrease in risk with the Mediterranean diet was 1%, you would be a lot less impressed than you were when you heard that there was a 30% decrease in risk. Interestingly, this paper that was originally published in 2013 was withdrawn because of problems with randomization, and then it was published again in 2018. This is the new abstract, and this time they actually did include the absolute numbers in the abstract. So the message here is that we all need to be really careful when relative numbers rather than absolute numbers are what we're looking at. And even more importantly, returning to Bernoulli, making the best choice involves not only knowing the numbers, but also knowing how you value the numbers. It turns out that there's many areas of medicine that fall into a gray zone, where there's not one clear right answer. And I'll give you an example from my own practice as an endocrinologist. One of the things we most commonly see are thyroid nodules, lumps in the thyroid gland, and the vast majority of these are benign, but some are malignant, and to evaluate these, we usually do a needle biopsy. But sometimes the biopsy doesn't give you a definitive answer either, sometimes because you can't get enough cells, more often because the cytology is indeterminate. Molecular testing then can be helpful, but again, that can be indeterminate as well. And then we need to decide if we're going to watch the patient or we're going to go to surgery. So not too long ago, I saw a patient who was in this situation. She was seen at each of the 3 major teaching hospitals at Harvard. She had a biopsy each place, and all of the biopsies were indeterminate. The ultrasound was not particularly worrisome. And so what are the numbers for that? The risk of malignancy in this setting is estimated to be between 5 and 10%. So she said to me, "What would you do?" Now, what would you do? That's a question we get asked all the time, I think, as doctors. So I said, if it were me, I would watch and wait. But if it were my husband, he would have had surgery yesterday. We're both looking at the same numbers. We have different mindsets. So we're not suggesting that the doctor and the patient have to have the same medical mindset. Sometimes being challenged can help you make a much better decision. But doctors need to understand and respect the patient's mindset, and the patient needs to be aware of the doctor's mindset also.
So let's return to the subject of controversies in medicine. All of us look to experts to help guide us. Who are these experts? Insurance companies in the United States market themselves as having the numbers. If you see at the bottom of the slide, it's all about health in numbers. We have the numbers, comfort in numbers, and the experts who will look at data and guide your medical decisions. So here's an advertisement from United Healthcare, one of the nation's largest insurers. It says this is a young woman who's a runner, she's active, and she has a painful knee. So she's being considered for surgery. United Healthcare says, you would like to know you're choosing the right doctor. So the insurance company tells you who the right doctor is. You would like to know you're choosing the right procedure. The insurance company tells you what is the right procedure. And then the kicker. You would like to know that you have the right outcome. Now, this audience well knows that no one, even the best of surgeons, can always guarantee the, quote, right outcome for any individual. Now, let's go back to the earlier controversies: cholesterol, blood pressure, aspirin, vitamin D cancer screening. In each case, multiple expert committees have come up with different recommendations, even though they're looking at the same data. For PSA screening, 3 different experts committees came up with 3 different recommendations. Similarly, for mammograms, 4 different expert committees came up with 4 different recommendations.
So why do these expert committees disagree? We believe they disagree largely because they reflect different mindsets. For example, the U.S. Preventative Services Task Force, which is a government agency, generally favors a minimalist doubter point of view. Less is more. And this has become an increasingly popular point of view recently, in part due to the rising costs of health care. Other professional societies represent a maximalist believer point of view. But none of these recommendations are strictly objective. Everyone's looking at the same data, but they value the information differently due to different mindsets.
So how can a patient, as an individual, with you as the doctor, make a decision when experts disagree? We think it's essential to assess 3 dimensions. First, the patient's medical mind or mindset: believer, doubter, maximalist, minimalist, technology or naturalism orientation. But that's just the starting point. Then you look at the numbers and try as best as you can to understand how the numbers apply to that individual. And finally, stories. Now, in terms of evidence-based medicine and scientific thinking, we often dismiss stories as mere anecdotes. But it turns out that research done by Daniel Gilbert, a psychologist at Harvard, and others, published in the journal Science, in terms of how to better estimate the impact of a certain outcome on your life, that second part of the Bernoulli equation, the utility, is best done by talking to someone, interacting with someone who's had the outcome, someone who's similar in background to you, to try to get your arms around their experience with a certain condition. And this, in fact, we learned from our field research, speaking with men who were struggling with prostate cancer to decide among surgery, radiation, or watchful waiting. Now, you have to be careful about anecdotes, the N of 1. But on the other hand, they can be extremely valuable to patients, giving a concrete, palpable sense of what life may be like with a certain medical condition. So we hope that the language that we proposed today, maximalist, minimalist, believer, doubter, technology, naturalism, will facilitate the process of shared decision-making by helping your patients understand and communicate their mindsets to you, the doctor, and also help you to explain your thinking to the patients. And we hope that by keeping in mind that there is always a subjective element in every expert recommendation, you can understand and explain to patients why the experts are disagreeing, and you'll be able to help your patients find the best treatment for them as individuals. Thank you.